Hello, everyone. Greetings from Boston. My name is Danny Talmor from Beth Israel Deaconess Medical Center and Harvard Medical School. The topic of my discussion today is pulmonary mechanics in COVID-19, a topic of great discussion now. These are my disclosures, none of which are relevant to this talk. And the crux of the question that we're talking about in this session is, does making a diagnosis of ARDS in patients with COVID-19 matter? A question which was directly posed by Martin Tobin in Chest this year. The question has been obscured largely by the avalanche of papers in COVID-19. So you can see in this graph up until May, published in The Economist, 4,000 papers and another 4,000 in print. So if at the beginning of March, each of us thought we could keep on top of the literature by being diligent, it's become clear that it's very difficult to discern the signal from the noise in the COVID literature. I'm going to try to examine this question of pulmonary mechanics and come up with some common sense recommendations. Now, Dr. Gattinoni and colleagues have postulated that there are two types of patients in COVID-19. Those who they call type L, signified by low elastance, low shunt, low weight of the lung, and low recruitability. But this is a specific phenotype that needs to be treated differently. On the other hand, type H, or high, are characterized by high elastance, high right to left shunt, high weight of the lung, and high recruitability. And the crux of the argument is that these are two different phenotypes, that type L is very different from our typical ARDS and may require a different approach to mechanical ventilation. The argument is based on the differences in compliance and shunt in these patients. And you can see from Dr. Gattinoni's work that there is a pretty wide distribution of lung compliance in COVID-19 patients, a wide distribution of right to left shunt, and that those patients who have a higher compliance and a lower level of shunt would do better in with a unconventional mode of ventilation. So given these considerations, to quote Dr. Gattinoni, the best we can do while ventilating these patients is buy time while causing minimal additional damage by maintaining the lowest possible PAPE and gentle ventilation. I would argue that those are recommendations that would be relevant to any patient under mechanical ventilation. There's been a number of case series in the literature which support this concept of a higher compliance phenotype in COVID-19. So this report out of France reported two sets of patients. They were able to identify a specific subgroup of patients with a higher respiratory system compliance, and that group actually had a better outcome measured in VFDs. So higher compliance, that phenotype, which Dr. Gattinoni calls the L type, would be associated with better outcome. This group, Dr. Antonelli in Italy, published actually this week another report showing indeed that COVID-19 was associated with a higher compliance. You can see that on the left. And in particular, when you calculated compliance per predicted body weight, it was significantly higher than patients who were non-COVID. Now, there's two things at play here. If you look at the distribution of the compliances on the left-hand graph, you can see that they're widely distributed both in COVID and non-COVID patients. So while they're statistically significantly different, clinically, these are probably not very different phenotypes, the COVID and non-COVID. Looking at the compliance per predicted body weight, compliance being higher in the COVID patients per predicted body weight, that may be an artifact of the risk of obese patients for COVID-19. So by dividing by the body weight, we may be seeing a higher compliance per predicted body weight. This paper by Eddie Fan and colleagues summarized up until the point of publication the compliances reported in the literature for COVID-19 patients. And you can see that on the top line of the bolded area. So compliances ranged from 26 to 50 across multiple case series. Again, compliances which are not significantly different from those reported in case series of patients with acute respiratory distress syndrome. The plateau pressures were relatively low, and the PEEPs that were applied to these patients were well within the range of typical ARDS. This paper from France demonstrated that the COVID-19 patients in the left-hand graph on the right side had compliances which were similar, very similar to those in non-COVID-19 patients, that there were patients in COVID-19 who could be identified as recruitable as there are in non-COVID-19 ARDS, and that the compliance in both high and low recruitability patients remained highly variable, as you can see on the chart in the right. So the summary of this report was there was really no difference in compliance between COVID-19 and non-COVID patients. This week in Lancet Respiratory Medicine, we saw a very large case series that came out of Italy, over 1,000 patients who had either COVID-19 or classical ARDS. And you can see on the top area of the graph, their COVID-19 patients seem to have a somewhat higher compliance than classical ARDS, but that difference, while statistically significant, again, I would argue is not clinically significant. The compliances of the patients with COVID-19 ARDS are well within the area of classical ARDS. Below, you can see the total lung weight of the calculated on a subset of patients who had CAT scans, and there was no significant difference between the COVID-19 patients and patients with typical ARDS. This study from our institution in Boston shows the heterogeneity of severity of patients with COVID-19. So we had 40 patients in whom we had placed esophageal balloons for their clinical treatment of COVID-19. And you can see the range of respiratory system and lung compliances in COVID-19 is quite large, between 20 and 50 for respiratory system compliance. And but all of those values are well within the area we would consider ARDS. When you look at the relationship between lung and respiratory system compliance, those are highly correlated, I think indicating that this is largely a pulmonary disease rather than having a significant chest wall component. Here we can see the PEEP requirements in order to maintain a transpulmonary pressure of 0 or greater. So if you look here, this is a transpulmonary pressure of 0. In order to maintain that transpulmonary pressure of 0, a wide range of PEEP values were required between 10 and 20. Not everybody got to that point, but even to maintain a transpulmonary pressure less than 0, patients required often PEEPs in the high teens. So this value of PEEP required to maintain a positive transpulmonary pressure seems to indicate that these patients do fall within the range of responses we would see in ARDS. Up here, you can see the end inspiratory transpulmonary pressure. And while the upper limit of normal for end inspiratory transpulmonary pressure in mechanically ventilated patients isn't well defined, an end inspiratory pressure of greater than 10 does indicate a relatively sick lung, and many of these patients fall into that area as well. So the data from the in-depth respiratory mechanics using esophageal pressure measurements seems also to indicate that these patients are what we would call typical ARDS. This report out of France, published this week, shows the response to various maneuvers between 24 COVID-19 patients and historic controls. So in this paper, they reported no difference in compliance or driving pressure, but they did report that the response to the oxygenation response to lung recruitment maneuvers, to prone positioning, to higher levels of PEEP, and the mortality rates were all very similar in COVID-19 and non-COVID-19 patients. Again, supporting that while there's a wide variation in mechanics in these patients, in the end, they do behave like typical ARDS. This is going back to a paper I showed before, Antonelli and group, showing that the COVID-19 patients often were PEEP responders and often responded better than non-COVID-19 patients. So they compared a historical cohort of non-COVID-19 to COVID-19 patients. Now, in the big picture, we should remember that ARDS is a syndrome with multiple entities. And even prior to COVID-19, we could see that compliance and oxygenation were not really related in ARDS patients. You could have a high compliance and very low oxygenation, and the opposite. And we know that compliance values are related to outcome. So here you can see in this recently published paper from LungSafe, the probability of dying increases as compliance is lower. This is an old lesson published 10 years ago, showing that non-survivors had lower compliances over their stay. So I would say that the argument over whether this is ARDS or not is a tempest in a teapot. Compliance is variable in COVID-19 as it is in ARDS. Hypoxemia and compliance are not related. Initial compliance and outcomes are related in COVID-19 and in ARDS. COVID-19 primarily affects lung mechanics. It's a pulmonary disease, and there are groups of patients who are recruitable and require higher levels of PEEP. So at the bedside, use the insights we've accumulated over years, individualize therapy to the patient, intubate those who have a high work of breathing, measure pulmonary mechanics, it's more important than ever, lowish tidal volumes, but it doesn't have to be 6 mLs per kilo, it can be a little higher, minimize plateau and driving pressures, individualize PEEP, and prone and ECMO patients who require it. And I'll end on a high note. This is a recently published paper from NYU showing that there seems to be a decrease in mortality from COVID-19 over time, matching for age, gender, and so on. So perhaps all of the things I've said above will be moot. Thank you very much.